Welcome to the Hospital Medicine Unplugged podcast.
It's good to be here.
We have a really important topic to cover today. We are recording this in February of 2026, and I think we need to start by just acknowledging the elephant in the room. For a very long time, I think throughout most of our training and, arguably for the first part of our careers, measles or rubeola, it just felt like a historical footnote.
It really did. It was a chapter in the textbook you memorized for the boards. It felt like it was in the same category as smallpox, something we had, conquered.
Exactly. It was a classic board review question, not a patient you ever actually expected to admit to your service.
You never thought you'd see a case. That sense of security was, well, in retrospect, it was incredibly fragile.
And that security has, for all intents and purposes, evaporated. The clinical landscape around measles has shifted so dramatically and so quickly in the last few years.
It's a completely different world now.
We're not just seeing isolated clusters anymore. We're seeing a pattern that suggests this is a present, and I think it's fair to say, an escalating global public health threat.
I agree completely.
So the premise of this deep dive is simple. We need to relearn measles, not as some kind of historical curiosity, but as a differential diagnosis that has to be at the very front of our minds right now, today.
We absolutely do. And to really grasp the agency of it, you have to look at the numbers, at the trajectory of where we've been.
Okay, let's do it.
If you just rewind the clock about a decade to 2016, we were at a historic global low for measles cases.
Right.
We had roughly 132,490 cases worldwide. Now, obviously, that's still a huge number, but in the grand scheme of epidemiology, it felt like the finish line was actually in sight.
It felt like elimination was a tangible goal.
It did. It felt inevitable, like we were just mopping up the last few embers of a fire.
But then the rebound hit.
And it hit hard. By 2019, just 3 years later, that number had surged from about 130,000 to 869,770 cases.
That's a staggering increase.
Right.
Almost sevenfold.
A sevenfold increase in 3 years. We saw these massive, devastating outbreaks in places like the Democratic Republic of the Congo, Madagascar, Ukraine, Brazil. The virus found every single crack in our global immunity wall.
And then, of course, you have the why now. We can't have this conversation in 2026 without talking about the long shadow of the COVID-19 pandemic.
It's the primary driver of where we are today. The pandemic didn't just disrupt our social lives. It completely devastated the routine primary care infrastructure across the globe.
We saw it in our own hospitals, in our own clinics. Well, child visits were canceled or moved to telehealth. Parents were, understandably afraid to bring their kids into a medical setting.
And the supply chains for vaccines were interrupted. The data just bears all of this out. Global first-dose vaccine coverage plummeted to 81% in 2021.
81%.
To put that in perspective, that's the lowest level we have seen since 2008.
So we lost more than a decade of progress.
In about 18 months, yes. We essentially created this massive global cohort of susceptible children who are now aging into school, traveling, mixing socially. They're a reservoir for the virus.
And that brings us to our local context. This isn't just a problem over there. Looking at the data from May of 2025, the United States is absolutely not exempt from this.
Not at all.
We're looking at 1,088 confirmed cases and, tragically, 3 deaths here.
And for every hospitalist listening, there's a statistic within that number that is just critically important.
Which is?
96% of those cases, 96%, occurred in individuals who were either completely unvaccinated or had an unknown vaccination status.
So this is fundamentally a preventable crisis.
It is entirely a crisis of undervaccination. But once that patient hits our emergency room, the preventable part of the story is over. At that point, we have to manage the pathology that's in front of us.
Which is our mission for this deep dive. We want to equip our peers. We need to go way beyond the basics we learned in med school. We need a comprehensive review of the clinical pathology, the transmission dynamics, which are frankly terrifying, the diagnostic challenges, and we have to spend significant time on the critical role of vitamin A in management.
Okay. Let's start at the beginning with the agent itself. It's a paramyxovirus.
When I think about measles, the very first thing that comes to mind is its transmissibility. We always hear this term, the basic reproduction number, or $20.
A famous $2.
Right. And the standard number you always see cited for measles is somewhere between 12 and 18.
That's the textbook number, yes.
And just for context for everyone listening, that means in a completely susceptible population, one infected person will, on average, infect 12 to 18 other people.
Which is already incredibly high. Compare that to the original strain of SARS-CoV-2, which had a number of maybe 2 to 3.
So measles is just on another planet in terms of contagiousness.
It's in the absolute upper echelon of infectious agents known to science. But there's a nuance here that I think often gets overlooked in these standard reviews. I was looking at some systematic reviews recently, and they show that Doherty to Luthers isn't some fixed biological constant for the virus. It is profoundly context-dependent.
What do you mean by that? How so?
Well, the intrinsic transmissibility of the virus itself is, yes, very high. But the actual dollars that we observe in real-world outbreaks can vary wildly based on the environment.
Okay.
We see estimates as low as 3.7 in some very specific sort of low-density settings. But on the other end of that spectrum, some studies have calculated in $2 as high as 203.3.
Wait, say that number again?
203.3.
That can't be right, 203. That sounds impossible. That sounds like a typo in the paper.
It sounds completely impossible until you start to model it in a high-density, completely susceptible environment. Imagine a crowded refugee camp, a packed school auditorium.
Or a busy hospital waiting room in the middle of winter.
Precisely. A busy ED waiting room. If you have a highly contagious airborne virus, high population density, and very low background immunity, the virus can just sweep through effectively everyone.
That number, 203, it really puts the airborne nature of this into a terrifying perspective. We are not talking about large droplets that fall to the ground within 6 feet.
No, this is true aerosolization. The virus is in microscopic particles generated just by breathing, let alone coughing or sneezing. But the critical piece of information for any clinician for infection control is the viability of that virus in the environment. This is where our standard protocols can fail us.
Right, because we're so used to droplet precautions. A patient with influenza leaves a room, you wipe it down, and the risk is largely gone.
With measles, that is absolutely not the case. The virus remains viable, infectious, in the air and on surfaces in an enclosed space for up to 2 hours after the index patient has physically left that space.
2 hours. That has just massive implications for patient flow and hospital safety.
It's huge.
I mean, think about the logistics. A patient comes in with a fever and rash. They sit in triage room 3 for 20 minutes while they're being worked up. The triage nurse has a flash of insight, suspects measles, and moves them to a negative pressure room.
Right.
Triage room 3 is now a hot zone. It's a biohazard for the next 2 hours.
Precisely. And anyone who walks in there is at risk. So a patient doesn't need any direct contact with the index case to become infected. A susceptible patient, maybe an immunocompromised oncology patient coming in for a lab draw, or an infant who's too young to be vaccinated, could walk into that same triage room 3 an hour later for a twisted ankle and inhale the virus.
It's a silent trap.
It is. And the attack rate reflects that efficiency. In a room of non-immune individuals, up to 90% of them will develop the disease after an exposure.
90%. There are very few pathogens on Earth that have a 90% strike rate.
Well, almost none.
Okay, so let's get into the timeline of infectivity, because this is the other factor that makes containment a complete nightmare. By the time we see the classic rash and make the diagnosis,
the horse has already left the barn, miles down the road.
the infectious period is our greatest challenge here. Patients are contagious starting 4 days before the onset of the rash.
4 full days.
And they remain contagious for another 4 days after the rash appears.
So you have this 8-day window of shedding, but half of it happens before anyone even knows the patient has measles.
So during that prodromal phase, those 4 days, the patient is actively shedding virus. They're walking around, they're on the bus, they're in the grocery store, sitting in our waiting rooms, coughing.
And they are shedding heavily. They feel sick, sure, they have a fever and a cough, but it looks like any other winter virus.
Combine that with an incubation period of 10 to 14 days, though the range can be anywhere from 7 to 23 days.
And you have this incredibly long silent window where an individual can be exposed, incubating, and then shedding virus before the diagnosis is even a remote possibility.
That high infectivity during the prodrome makes containment almost impossible. It forces us to be detectives. We can't wait for the rash to, slap us in the face. We have to be able to identify the pattern during the prodrome.
Which brings us to the clinical presentation. The classic syndrome is described in 3 phases, and mastering that first phase, the prodromal phase, is really the key to catching this early.
And this typically occurs on days 2 through 4 of the illness.
That's right. And it's characterized by fever, often quite high, and the famous 3 C's.
Cough, coryza, and conjunctivitis.
The 3 C's.
Now, let's be realistic. In February of 2026, a patient with fever, cough, and a runny nose coryza that describes about half the patients in my waiting room on any given day.
It's the ultimate non-specific viral prodrome. It looks like influenza, it looks like RSV, it looks like adenovirus, it looks like the common cold.
That's the cognitive trap right there.
It is, but we need to look closer. The coryza isn't just a runny nose, it's often profuse. The conjunctivitis is often quite marked. It's not just a little bit of redness. Patients can be photophobic, their eyes are watering constantly, it's really irritating.
And the cough.
The cough tends to be this very harsh, brassy, non-productive, and persistent cough. It's a miserable cough.
And within this phase, before that big rash breaks out, we have the one sign that can potentially give the whole game away.
The complex spots. The pathognomonic sign.
Described in textbooks as looking like grains of salt on a red background.
That is the classic description. They're tiny, maybe 1 to 2 millimeters, bluish-white plaques on the buccal mucosa. You need a good light, and you need to look carefully, usually opposite the lower molars.
And their timing is critical.
Absolutely critical. They typically appear 1 to 2 days before the rash erupts. They are your early warning signal.
Now, I feel like in my career, I've looked for complex spots 100 times on kids with viral syndromes, and I've never once seen them. How reliable are they really?
That is the crucial point. They are pathognomonic, meaning if you see them, you can essentially hang your hat on the diagnosis of measles. It's done.
Okay.
But, and this is a huge but, they are only present in about 60 to 70% of cases.
So the sensitivity is poor.
Very poor. The absence of complex spots does not rule out measles. And to make it even harder, they're transient. They might only be there for 24, maybe 48 hours, and then they fade just as the rash is starting to appear. So if you miss that very narrow window, you miss the sign completely.
So after the prodrome, with or without complex spots, we move into the exanthem phase.
Yeah.
This is the main event. This is what everyone thinks of when they think of measles.
This usually hits about 2 to 4 days after the fever started. And interestingly, the fever often spikes quite high, up to 40 degrees Celsius or 104 Fahrenheit, right as the rash appears.
And the rash itself is an erythematous maculopapular rash.
Right, red spots and bumps.
But the distribution pattern is the key to the physical exam. It's classically craniocaudal.
Meaning it starts at the head and moves down the body, cranium to caudal.
I always visualize it like someone pouring a bucket of red paint over the patient's head and letting it drip down.
That's a very accurate and memorable visual. It begins on the face and the head, specifically along the hairline and behind the ears. That's a classic starting point.
Behind the ears, that's a good pearl.
Then it spreads downwards to the trunk and finally out to the extremities over a period of about 3 to 5 days.
And the character of the rash itself changes as it moves down the body, right?
Yes, it does. On the face and the upper body, it has this very strong tendency to become confluent. The individual spots merge together to form these large, blotchy red patches.
Okay.
But as it moves down to the legs and the feet, it tends to remain more discrete. You can still see the individual macules and papules.
And as it resolves,
Oh.
how does it fade?
It fades in the exact same order it appeared. It clears from the face first, then the trunk, then the legs. It can leave behind this brownish, coppery discoloration for a week or two, and sometimes some fine, branny desquamation, like a light peeling of the skin.
And that takes us into the third phase, the convalescent phase.
Right. In an uncomplicated case, and uncomplicated is the key word there, recovery is typically within 7 to 10 days of the rash onset. The cough might linger for a bit longer, but the fever and rash are gone.
Okay, but before we dive into the complications, which are really the heart of why we're having this discussion, I want to loop back to the diagnostic challenge.
Yes.
Because relying on that classic triad of fever plus rash plus one of the 3 C's, that classic teaching is, in 2026, insufficient and potentially dangerous.
It is entirely insufficient. And the reason, oddly enough, is because of the success of the vaccine era. We have to talk about modified measles.
This is the presentation we see in people who have been previously vaccinated.
Exactly. We are seeing breakthrough cases. These are patients who maybe only got 1 dose of MMR, or maybe they got 2 doses but had waning immunity years later, or they were just a primary non-responder to the vaccine.
So their immune system has some memory of the virus, just enough to blunt the disease, but not enough to prevent the infection entirely.
Precisely. The disease expression is muted. They might have a lower fever or no fever at all. The 3 C's might be absent or just very mild, like a simple cold.
And the rash?
The rash can be completely atypical. It might not start at the head. It might be faint or non-confluent or look more like a drug rash. It can be a real diagnostic puzzle.
And this is an infection control nightmare, because a clinician sees a mild rash and a low-grade fever in a vaccinated person, and they're thinking, oh, it's a drug eruption or some non-specific viral exanthem. They're not thinking measles.
So they don't institute airborne precautions. And that patient, even with a modified case, is still shedding virus. Maybe less virus than a naive host, but they are still contagious.
This is why clinical diagnosis alone is unreliable. We cannot just trust our eyes anymore.
You can't, which means you need to maintain a very broad differential diagnosis for any patient with fever and a rash.
So you're thinking rubella, roseola, scarlet fever from strep.
Drug eruptions are a huge mimic. You have to consider dengue or chikungunya if there's a travel history. Even things like Kawasaki disease or other viral exanthems like parvovirus B19.
Given all that ambiguity, laboratory confirmation is not optional. It is the absolute standard of care. We cannot guess with this.
We cannot. The gold standard for acute diagnosis is RT-PCR. We're looking for detection of viral RNA. It's highly specific.
And the best samples for that?
A nasopharyngeal swab or a throat swab are the preferred samples. They have the highest yield early in the illness.
And we can also use urine, is that correct?
Yes, that's a great point. Viral RNA can often be detected in urine, and sometimes it stays positive in the urine for a longer period than it does in the respiratory tract, so it's a good backup sample to send.
What about serology?
Serology is still very important. A measles IgM by ELISA is the most widespread method globally. It's generally positive by the time the rash appears.
But there's a pitfall there, right?
There is. Up to 20% of patients might still be IgM negative in the first 72 hours of the rash. So if you test on day 1 of the rash and you get a negative IgM, you can't rule out measles.
That is such a critical pearl.
Yep.
Do not let a negative IgM on day 1 of the rash talk you out of the diagnosis if your clinical suspicion is high.
Exactly. Repeat it in a few days, but more importantly, send the PCR. The PCR will be positive in that acute window, and it's much faster and more definitive.
And genotyping. I hear about that for outbreaks.
Genotyping is primarily a public health tool for epidemiologic surveillance. It allows the CDC or the WHO to track the origins of these outbreaks. Is this a strain from Europe? Is it from Southeast Asia? It helps connect the dots, but it doesn't change your acute management of the individual patient.
Okay. Now, I want to pivot to the really heavy part of this discussion.
Yeah.
We need to talk about why we worry so much about this diagnosis. There's a dangerous tendency among the lay public and maybe even some younger clinicians who haven't seen it to think of measles as just a rash, a miserable week, but then you get over it.
That is a profoundly dangerous misconception. The morbidity and mortality profile of measles is incredibly significant. This is a systemic illness that can ravage the body.
The epidemiology of the complications is just striking.
It is. Approximately 30 to 40% of patients will develop at least one complication. Think about that number. 1 out of every 3 people who get measles.
That is an unbelievably high rate for what people dismiss as a simple childhood illness.
And the risk isn't evenly distributed. It follows a classic U-shaped curve. We see the highest risk for severe complications in infants under the age of 5, and then again in adults over the age of 20.
And there are other risk groups.
Yes. Pregnant women, any immunocompromised individual, and very importantly, those with malnutrition, specifically vitamin A deficiency.
Let's break down the common complications first, the things we'll see most often.
Otitis media is very common, seen in 7 to 9% of cases. Diarrhea occurs in 8 to 10%, and it can be severe, leading to significant dehydration, especially in young children.
But the most dangerous of the common complications is pneumonia.
Without a doubt. We need to state this as clearly as possible. Pneumonia is the single leading cause of measles-associated death.
It occurs in 1 to 6% of cases, which sounds like a small percentage, but because measles is so widespread in an outbreak, that small percentage translates into a large number of deaths.
Absolutely. And it's important to note there are 2 flavors of this pneumonia.
Okay.
First, you can have a primary measles pneumonia. This is a giant cell pneumonia caused directly by the virus itself, destroying the lung tissue. It's often seen in immunocompromised patients and can be rapidly progressive and fulminant.
And the second type?
The second and more common type is a secondary bacterial pneumonia.
So superinfection.
Correct. The measles virus damages the respiratory epithelium and profoundly suppresses the immune system. This just rolls out the welcome mat for bacteria like Staphylococcus aureus, Streptococcus pneumonia, Haemophilus influenza to invade. This is the more common cause of death in otherwise immunocompetent children.
So, while pneumonia kills via acute respiratory failure, the neurologic complications are perhaps the most feared due to their severity, and in some cases, their grim inevitability once they begin.
The neurologic spectrum of measles is genuinely terrifying. We generally categorize them into three distinct entities, and it's really important for clinicians to distinguish them because their timing, their pathophysiology, and their prognosis are all very different.
Let's walk through them one by one. First, acute post-infectious encephalitis.
This is an autoimmune reaction. It's not the virus in the brain, it's the body's immune system, triggered by the measles infection, mistakenly attacking the myelin in the brain.
And autoimmune demyelation.
Exactly. It occurs in approximately 1 per 1,000 cases.
What was the timing on this?
It happens fast. Within the first week or so of the rash appearing, the patient seems to be getting over the rash and then suddenly develops altered mental status, seizures, focal neurologic deficits.
And the outcomes are not good.
Not at all. It carries a mortality rate of roughly 20%. And among the survivors, a significant percentage, maybe 25 to 40%, are left with permanent neurologic sequel A blindness, deafness, seizure disorders, intellectual disability.
Okay, so that's the first one. The second entity is measles inclusion body encephalitis, or MIBE.
MIBE is a different beast entirely. It specifically targets immunocompromised patients, those with HIV or leukemia or solid organ transplant recipients.
And the pathophysiology is different.
Completely different. Unlike the autoimmune mechanism of the first type, MIBE is a direct, persistent viral invasion of the brain. The virus is actively replicating in the neural tissue.
And the timing is more variable.
Yes, it can present anywhere from 7 days to as long as 6 months after the initial infection. It's a smoldering infection in the brain.
And the prognosis?
It is devastating. The mortality is essentially 100%.
100%. That's a sobering number.
It is. But if MI is the horror story for the immunocompromised, the third entity is the lingering nightmare for every pediatrician and parent. And that is subacute sclerosing panencephalitis, or SSPE.
This is the one that keeps people up at night.
It should. SSPE is a fatal, progressive, degenerative disease of the central nervous system. The incidence is estimated at somewhere between 7 and 11 per 100,000 cases of measles. That might sound rare, but in a large outbreak, those numbers add up.
And the most terrifying aspect of SSPE is the latency, the time bomb aspect of it.
Exactly. It doesn't happen during the acute infection. It occurs on average 7 to 10 years after the child had measles.
So let's just paint that picture clearly for everyone. A child gets measles at age 2. Maybe they were unimmunized, or maybe they were just too young for their first vaccine dose. They have the fever, the rash, they get sick, but they recover.
They recover completely, it seems. They go to kindergarten, they learn to read, they play sports, they have birthday parties. They seem like a perfectly healthy kid.
And then, at age 10 or 12 or 14, they start to change.
It begins insidiously. Stage 1 is subtle behavioral and personality changes. Their school performance starts to decline. They become irritable, forgetful. Parents might just think it's puberty or maybe ADHD.
But then it progresses.
It progresses rapidly and relentlessly. Stage 2 involves massive myoclonus, these violent muscle jerks, seizures, and progressive dementia. They lose the ability to walk and talk.
And from there,
Stage 3 is autonomic instability, rigidity, and eventually a persistent vegetative state or coma. Stage 4 is death.
and once the symptoms of SSPE start,
There is no treatment. There is no cure. Once it begins, mortality is 100%, typically within 1 to 3 years of onset. It is a slow, cruel, inevitable progression.
that is the context we need to have when we talk about this disease. It's not just about preventing a week of fever. It's about preventing a healthy 10-year-old from dying of a neurodegenerative disease.
Absolutely.
Beyond these direct, devastating complications, there's a more subtle, systemic immunologic impact that we're only really beginning to understand fully now. The concept of immune amnesia. I find this to be one of the most fascinating and disturbing aspects of measles pathology.
It is a profound and elegant, in a terrifying way, mechanism. For a long time, epidemiologists noticed that after a big measles outbreak in a community, the all-cause mortality in children would stay elevated for years.
Not just deaths from measles itself, but deaths from everything else. Diarrhea, pneumonia.
Exactly. And the research in the last decade or so has finally explained why. Measles infection causes this deep, prolonged form of immunosuppression that can last for 2 to 3 years after the infection.
How does it do that? What's the mechanism?
The virus has a specific tropism for and infects CD150 positive cells, and that cell population includes our memory B cells and memory T cells.
So it specifically hunts down and kills the very cells that hold our immune memory.
It essentially wipes the immune system's hard drive. It deletes the pre-existing antibodies and cellular memory to other pathogens that the child has encountered or been vaccinated against in the past.
So let me get this straight. If a child had chickenpox, or had the flu, or was fully vaccinated against tetanus or polio, the measles virus can effectively erase that protection.
It can. The child becomes susceptible again to diseases they were previously immune to. That is, immune amnesia.
The consequence, then, is an increased susceptibility to all sorts of secondary bacterial and viral infections that are completely unrelated to the measles virus itself.
And this implies that the true mortality burden of a measles outbreak is significantly higher than what we officially count. When we look at the death toll, we aren't attributing those later deaths from rotavirus or bacterial pneumonia back to the immune damage that was caused by the measles infection years prior. But biologically, they are absolutely linked.
It's a long tale of morbidity and mortality. It really reframes the disease not as a simple acute event, but as a chronic immunologic injury with long-term consequences.
That is exactly the right way to view it.
Okay, let's shift gears now to management and therapeutics. So we have a patient in the hospital. We've confirmed the diagnosis with a PCR test. We have them in airborne isolation. What do we actually do for them?
The first thing to recognize, and this can be frustrating, is the status of antivirals. Despite all of our medical advances, there is no specific approved antiviral therapy for measles.
We don't have a Tamiflu for measles.
We do not. The drug ribavirin has been used off-label in some very severe cases, particularly for measles pneumonia in immunocompromised hosts. But the data is very mixed, and it is absolutely not the standard of care for uncomplicated cases.
So we are back to supportive care.
We are. Good old-fashioned supportive care is the mainstay. Hydration is absolutely key, as these patients can lose a lot of fluids from high fevers and diarrhea.
Yeah, and fever management?
Antipyretics like acetaminophen or ibuprofen for comfort and to reduce insensible losses. Good nutritional support is also important.
What's the role of antibiotics?
Antibiotics are only indicated if you have a proven or very strongly suspected secondary bacterial infection.
Like that staphylococcal pneumonia or the otitis media we discussed earlier.
Exactly. You do not use antibiotics for the primary measles viral pneumonitis itself, and prophylactic antibiotics are generally not recommended as they don't prevent secondary infections and can just select for resistant organisms.
However, there is one intervention that is active management. It's not just supportive, and that is vitamin A supplementation.
This is the single most critical intervention. If you take one thing away from this entire management section, it is this. Vitamin A is not a suggestion. It is not an afterthought. It is a requirement for these patients.
I think some of our peers might view vitamins as soft medicine. You know, oh sure, give them a multivitamin, it can't hurt, but this is completely different.
This is high-dose pharmacologic therapy with a proven mortality benefit. Let's just look at the evidence base. Large-scale randomized controlled trials, particularly from resource-limited settings, have shown that vitamin A supplementation reduces mortality in children by 34 to 50%.
A 50% reduction in mortality.
And systematic reviews that have pooled this data indicate a 62% mortality reduction when 2 doses are given as recommended.
That is a massive mortality benefit. That's better than many of the expensive high-tech drugs we use in the ICU every day.
It is. And the mechanism of action explains why it's so effective. Why vitamin A specifically?
Right. What is the connection between this virus and this vitamin?
The measles virus actively depletes the body's vitamin A stores. The high metabolic rate from the fever, the reduced oral intake, and the direct effects of the virus cause an acute, profound deficiency, even in children who were previously well-nourished.
And vitamin A is crucial for what?
It's essential for the normal regulation of the immune system, but critically, it is required for the maintenance and repair of epithelial integrity.
So the lining of the gut, the lining of the lungs, the surface of the eye.
Exactly. Think of vitamin A as the mortar that holds the bricks of our mucosal barriers together. The measles virus comes along and strips that mortar away. This leads to mucosal breakdown, which allows for the severe diarrhea, the bacterial superinfection in the lungs, and the corneal ulceration that can lead to blindness.
So by giving high-dose vitamin A, we are actively rebuilding that barrier and limiting the collateral damage from the virus.
We are giving the body the raw materials it needs to repair itself and fight off secondary invaders.
Okay, for our peers listening, let's get very specific on the dosing guidelines from the WHO and the AAP. We need to know these numbers cold.
The indication is simple and broad. Administer vitamin A to all children hospitalized with acute measles. Do not wait for labs to confirm a deficiency. Do not wait for clinical signs of deficiency. If they have measles, they get vitamin A.
And the schedule for administration.
2 doses, given on consecutive days, 1 dose on day 1 and a second dose on day 2.
Okay, let's break down the dosage by age because it varies.
For infants who are less than 6 months old, the dose is 50,000 IU.
50,000. And for infants who are 6 to 11 months old.
That dose doubles to 100,000 IU.
And for all children 1 year and older?
The dose is 200,000 IU.
These are very large doses, way more than a daily requirement.
There are therapeutic repletion doses designed to overcome the acute deficiency caused by the illness.
Is there ever a situation where a third dose is needed?
Yes, a third dose is indicated 2 to 4 weeks later if the child has clinical signs of vitamin A deficiency, things like xerophthalmia, which is dry eyes, or bitose spots on the conjunctiva, or if the child has severe underlying malnutrition.
And what about for adults? We are seeing more and more adult cases of measles.
The data is less robust for adults, but given the shared pathophysiology, we should strongly consider supplementation for adults as well, especially if the case is severe or if deficiency is suspected for any reason. But the strict evidence-based protocol is most emphasized in the pediatric population, where that mortality benefit is so clearly proven.
Okay, let's move to prevention and the broader public health implications. We touched on this at the beginning, but let's clearly define the goal here.
The goal with a virus this contagious is herd immunity. We talked about that staggering 12 balls of 12 to 18 and potentially much higher. To interrupt the transmission of a virus that spreads like wildfire, we need to achieve and maintain community protection levels of at least 95%.
95%. That is an incredibly high bar. It allows for almost no margin of error.
It allows for almost no vaccine hesitancy and no gaps in access to care. And that 95% target is for 2 doses of a measles-containing vaccine, like the MMR.
What's the efficacy of the vaccine?
A single dose is about 93% effective at preventing measles. A second dose gets that efficacy up to about 97%.
So the vaccine efficacy itself isn't the problem. The tool works.
No, the MMR vaccine is a triumph of modern medicine. It's safe and it's highly effective. The failure is not in the tool, it's in the delivery and uptake of the tool.
Which brings us back to the gap we're currently facing.
We are currently sitting at roughly 81% global first dose coverage.
The gap between that 81% and the required 95%.
That 14% gap is where the virus lives and thrives. That is where the massive outbreaks in 2019 came from, and it's where the current cases we're seeing in 2026 are coming from. The virus is like water. It finds the lowest point. It finds the pockets of unvaccinated individuals, whether they are clustered geographically or clustered ideologically, and it explodes.
It really is a perfect storm. You have this incredibly high transmissibility, the physics of the aerosol, you have declining vaccination rates, the sociological impact of the pandemic and misinformation, and you have these severe life-altering complications, pneumonia, SSPE, immune amnesia.
And that really summarizes the entire situation. We have a virus that can linger in a room for 2 hours, infect 90% of the susceptible people who walk into that room, and then potentially kill them with pneumonia or condemn them to a fatal neurodegenerative disease a decade later.
The clinical takeaway for our listeners has to be vigilance. Diagnosis can't just be a hunch. We need to have a very low threshold to isolate any patient with a plausible story and fever and rash.
And then confirm it. We need PCR and IgM confirmation. We can't afford to be wrong.
And, once confirmed, strict adherence to the vitamin A protocols. It is the one therapeutic tool we have that significantly slashes mortality. Don't forget it. Don't skip it.
Please do.
As we wrap up this deep dive, I want to leave our listeners with a final thought, and I want to return to that concept we discussed earlier, immune amnesia.
Please do. It's the most haunting aspect of this disease for me.
When we see a patient with measles, we are not just looking at an acute illness that will last a week or two. We are potentially looking at a patient whose entire immunologic history has been reset to 0.
Right.
A single case of measles doesn't just threaten that patient with complications of measles. It potentially erases their immune memory against dozens of other pathogens for years to come.
It compounds the public health burden in ways that our standard mortality statistics simply fail to capture. We might save a child from measles pneumonia today, but they might die from influenza or pneumococcal sepsis next year because the measles virus stole their protection.
A truly sobering thought to end on, but a necessary one, I think, to fully understand the stakes of what we're up against.
Thank you for listening to Hospital Medicine Unplugged.